Okay, I think participants have stopped streaming in. So good afternoon, everyone. Thank you for joining PrEP in Women. I think this is a really exciting session that we have. We're going to have 3 different presentations today. My name is Dvora Davey, and I'm an epidemiologist at UCLA. And I'm also based at the University of Cape Town in South Africa. I do research on PrEP in women. So I'm really excited to learn from colleagues today. I would like to invite the panelists to introduce themselves as they present. So the first one we have today, just a reminder that please stay muted, use the chat for questions and comments, and remind all of you that are presenting that you have 12 minutes maximum, and there'll be a Q&A time after. So we're going to first learn about examining interests in PrEP delivery modalities among Ghanaian immigrant women in the United States from Gloria Aidoo-Frimpong and David Adzrago. So Gloria, you want to introduce yourself and get started? Thank you so much.
Okay, thank you so much. Like she mentioned, I'm Gloria Aidoo-Frimpong. I am a 4th-year PhD candidate at the University of Buffalo, and I will be presenting with my colleague David, who is also a PhD candidate at the University of Texas. And today our research would focus on immigrant women in the US, African immigrant women, and also PrEP delivery modalities. So a quick background on African immigrants in the US. So we do know that African immigrants are one of the fastest growing immigrant population in the US. Between 2010 and 2018, there was a 52% growth. And when I say immigrants, I mean immigrants and the refugee population, because usually they are put together with the data. The data is always aggregated. We know that there are very stark disparities in infection rates, especially among ethnic and minority groups when it comes to HIV in the United States. And research suggests that African immigrants actually have a 6-fold HIV transmission rate compared to the general US population as well. Available data also indicates that a disproportionate burden of the rate of HIV diagnosis among African immigrants is actually borne by women. So among African immigrant women, WHO diagnosis rates are 12 times higher than women in the general US population. And when compared with their white counterparts, it's 36 times greater. So this shows that, prevention opportunities may not be effectively reaching this population in ways in which we may want it to reach them. Pre-exposure prophylaxis, PrEP is highly efficacious, but uptake remains very low among women generally in the United States. And to date, the data on acceptability of PrEP among at-risk Africans are really absent globally and in the United States as well. So with strong evidence that PrEP is really effective and safe, it becomes very essential for us to deliver PrEP for women in ways that may meet their needs. The current development of long-acting forms of PrEP also offers a potential advancement in the field of HIV prevention, and particularly for those who would face some form of challenges using an oral regimen. So we have the different forms of PrEP that are currently in different phases of testing, which is the implant and the intravaginal ring, with the injectable PrEP currently, thankfully, approved by the FDA in the United States. So really what we wanted to look at was we wanted to look at the factors that were associated with the willingness, right, to use any of the different modalities of PrEP, as well as the prevalence of, any of these modalities, the willingness to use it among Ghanaians who are a subgroup of African immigrants in the US. So we recruited 236 Ghanaian immigrant women through WhatsApp, and WhatsApp is a social media platform for conversation, very popular among African immigrants in the United States in May 2021. Inclusion criteria, you had to be 18 years and above, you had to be born in Ghana, you are currently living in the United States, you are able to use WhatsApp and also able to read in English. And for our data analysis, we use descriptive, bivariate, and multivariable logistic regression using Stata. So my colleague David will give us the results, what we found.
So our descriptive and bivariate analysis were performed to estimate the proportion of the sample willing to use PrEP modality based on their socio-demographic characteristics. We found that about 80% or 81% of the 236 participants were willing to use a PrEP modality. And the willingness to use PrEP modality was associated with gender, sexual identity, annual household income, and employment status. The higher proportions of people who were willing to use a PrEP modality were cis women, heterosexuals, those who had annual income of 75,000 or more, and those who were employed full-time. So we'll be looking at our multivariable logistic regression analysis of the association between the willingness to use PrEP modality and the social demographic characteristics of the participants. So our regression analysis showed that participants who were within ages 25 to 34 years had less than college education, or part-time students were more likely or willing to use different PrEP modalities. Those who were trans women, gays, or lesbians, or had household income of 20,000 to 35,000 were less likely to be willing to use a PrEP modality. My colleague from here will be taking us through the discussion of these findings.
This actually study also gives us like initial evidence concerning the preferences of immigrant women, Ghanaian immigrant women in the US, and the high level of hypothetical PrEP acceptability among women in our study suggests that there is a potential interest in its use. And this interest could also be as a result of the belief that much of their risk factors are due to things that are really out of their control, including partners having concurrent relationships and also just challenges with negotiating condom use. Whilst not pictured in the results that we showed, it was shown that oral pill was really the preferred delivery method for most women. And this could probably be because the pill is self-controlled, it requires no specific actions or negotiation at the time of sex. And then also this particular method holds promise for women who have really limited power to really negotiate condom use. Also, it could be that their familiarity with birth control pills, which is the most predominant form of contraceptive use, especially in Ghana, could be informing this preference. Of note, trans women in this study were, less likely to use PrEP, and it could really be as a result of, the different intersecting stigma having to do with their identity as Ghanaians, also within the healthcare system, just these other structural stuff. And also people with less income within this population were also willing to not use PrEP. Interventions that are geared towards women within this population may want to consider using really client-centered approaches that actually considers the women's preferences, their needs and values as well. But this study was not without some limitations, so David would let us know what these are.
Yeah, so although our study has some strengths, it also has some limitations, as in many studies that need to be noted. First, Ghanaians that do not speak English were not included in the study. And this may not, so because of this, we may not be able to generalize our findings beyond those who speak English. Also, our sample size of 236 appears to be small. We may not be able to generalize our data or findings to the larger Ghanaian community in the United States. Furthermore, the responses were self-reported by the participant. Therefore, self-reported and social desirability biases might have occurred and resulted in underestimation of our findings. Additionally, this study was cross-sectional. As a result, we could not make any causal inferences since we did not determine temporal sequence between our dependent and independent variables. We therefore estimated and interpreted associations in this study. So with future directions based on the limitations of our findings and the study, we would like to make the following recommendations. More studies in this population are needed, especially qualitative studies, to explore reasons driving the preferences for different PrEP modalities. Longitudinal studies are needed to assess temporal changes in PrEP use over time among this population. This will help to make causal inferences about the relationship between PrEP modalities and their related factors. Also, there is a need to expand the study to cover a larger sample of women to have statistical power to generate more representative findings.
So these are contact information for David and myself. And thank you so much. Any questions, comments?
Thank you very much, both of you, for your great presentation. I think I learned a lot, and I think the others did as well. I think we'll keep the questions for the end of the presentations for now. I'll keep a record of Nina and others' questions, and then we can start at the end. So I think we'll move on to the next presentation. And the next presentation is entitled, I Want to See What That's About, Black Women's Insights on Accessing PrEP via Telehealth app. And Drew Mack will be presenting this
of
today.
a higher socioeconomic status, and his neighborhood, he was.
Hi, thank you so much. And good morning, everybody. My name is Drew Mack. Thank you for coming today. I'm so excited to be presenting for you all. Today's theme of resilience and shifting the paradox is so empowering. And I started this work during my postbac at Charles Drew University in Watts, Los Angeles, where I had the opportunity to be a research assistant to Dr. Moorhead G. And at the time, I was also at the HIV Oasis Clinic. And so doing this work was really transformative. And without further ado, I will just get started. This is, I Want to See What That's About, Black Women's Insights on Accessing PrEP via a Telehealth app. So many of us in this room are probably very familiar with this graph. And for those who aren't, this is LA County's most recent rate of HIV diagnosis among women. There's clearly an outlier on this graph, that outlier being Black women. Despite seeing a 55% decrease in new infections among Black women still have 20 times the rate of HIV infection among white women and 4 times the rate in comparison to Latinas. And this is despite the fact that PrEP, a highly effective preventative measure against HIV, has been improved since 2012. And if you look at the graph, you can see between 2012 and 2019, when this data was extrapolated, there isn't a drastic decrease in that gap as we would have hoped to see. So that brings us to the question, how can we prevent HIV among Black women? And one of the most promising methods is perhaps telehealth, as evidenced by multiple studies that consider the multi-level barriers that Black women face as a unique group, and the proposition that web-based interviews can meet these unique needs. And so there's multiple studies that have explored the relationship between promoting, sexual and reproductive health with mobile health tools and an increase in Black women being proactive about their sexual health. And it helps when these interventions are culturally competent and really tailored to the unique demographic that is Black women. So, as I kind of mentioned, telemedicine has this potential to decrease HIV among Black women through accessibility. And so our objective was to really understand, the target demographic being Black women in South Los Angeles. And so to use qualitative interviews to explore Black women's perceptions of using telehealth through an app. So just kind of your general, if you've used the CVS pharmacy app, and then using specifically telehealth to access PrEP. So kind of adding in that HIV intersection. And that is exactly what we did. So here is an example of a focus group. And so our methods, Braun and Clark thematic analysis guided by the grounded theory methodology was employed to analyze focus groups, recruited using convenience and snowball sampling. Group discussions were conducted with Black women in a large metropolitan area of Southern California, also known as LA, South Central, and inclusion criteria were HIV negative Black women aged 18 to 39 who engaged in condomless sex with a man in the last 12 months. And so some of the results from our focus group, we ended up with 5 focus groups, averaging about 4 to 5 women per group for a total of 21 Black women. As I mentioned, that's here in Los Angeles. And of those 21 women, 80% or 17 have access to a regular primary care doctor. The median age was 33 years. 80% are aware of PrEP. 20 or 95% have insurance. A little over half, at 52%, have used apps for health, and 100% use a smartphone. So what did we find out? So the qualitative data analysis were performed using following data collection with line-by-line process coding, and that led to the establishment of a couple of themes across the focus groups. Each theme actually corresponds with a greater characterization of the multi-level barriers to care. So individual factors being, the unique perspective of one person, the interpersonal and community factors, which include how these interventions might affect somebody's social standing or interpersonal relationships, and the structural factors, which take into account the systemic barriers that many of these women might face in accessing these resources. And so the three themes identified were the convenience of telemedicine, the importance of setting and advertising for a PrEP app, and the creation of safe spaces in the virtual world of telehealth. So getting into it. So first theme, the convenience of telehealth, and many women are seeing general telehealth apps as convenient. So one woman says, I always like getting my test results and stuff because it's tangible for me and quicker for me. I don't like the whole call or not call if nothing's wrong thing, which sometimes happens in the clinic. And then seeing PrEP apps specifically as convenient. I think it's like just the convenience of it. And also it's like maybe some people are private. If they are scared to know their status, maybe they just feel better like that. And then seeing accessing PrEP via telehealth as discreet. I mean, that's discreet, a discreet way, because it's not everyone's business, but maybe everybody should be doing it. So you see that there is clear interest, and discretion is a big thing here. People do not want their business in the streets. So now we move into the importance of setting for PrEP ads, taking this into account. So we're thinking about the average millennial woman who has a smartphone. And so from the focus group, I think by advertisement on your phone, Facebook or something, or your doctor gives you a link or sends you a link or something to access the telehealth. Another woman says, I think especially when you said the influencers, the people on YouTube, the moment you see them doing something, you're kind of like, I want to see what that's about. So they're like, this is me on day 1 of PrEP. This is me on day 30 of PrEP. This is how I felt. So it would normalize it. I think that's really important. And then targeting those without social media, which is also a very real demographic. Maybe they can have a little telehealth kiosk spot on, like at a CVS or something, where you can just go into the kiosk in case your phone is broken and just be talking in there, the CVS or a Rite Aid. So those were interpersonal and community factors. And now we're moving into those structural factors, which are having a mistrust of telehealth. So one woman's experience was, I reached out to the doctor. The doctor is the one that I create somewhat of a relationship with to ask questions to. So I felt like when the nurse called me back, her answer was generic. I reached out to the doctor, but it was a representative that got back to me. Another woman says, I'm not even that old, but I don't feel comfortable with that stuff. To get your information quick right away, that's perfect, but I'd rather go into the doctor. And lastly, but maybe most importantly, is feeling stigma towards picking up PrEP. If you have a personal lifestyle preference and you're at this telehealth kiosk, let's say it was especially for PrEP, you don't want people approaching you and questioning you about your lifestyle or trying to solicit you for relations. And so that's why it is so important that women feel safe when accessing these resources, because there's just so many multi-level barriers that might be a reason why we see that gap in care and in increased infections. So to discuss, Black women identified benefits of PrEP telehealth, including convenience, accessibility, and reduced embarrassment about accessing PrEP. And the concerns include the loss of direct contact with their provider through telehealth and fear of private information being released. Limitations, of course, this was a qualitative study and the findings are not meant to be generalizable. Limitations include small sample size and the use of convenience and snowball sampling. Moving into future directions, I think the best thing we can do is continue to talk to the communities that we hope to impact. We can make all these assumptions, but it's different when you are on a one-on-one level, hearing the actual perspective and hearing from the patient what would best serve them. So to further combat the HIV epidemic, healthcare systems need to take this into account and utilize telehealth-based PrEP, because people have smartphones and people use them, but in a way that is discreet and focused on the patient-doctor relationship, because nobody wants to be shunted aside to someone who isn't their provider or harassed when trying to access their prescription. And for me personally, I'm going to take in this experience as I move into my first year of medical school and take these foundations into my role as a physician advocate. So thank you so much. I would like to acknowledge a few people, namely Dr. Morhaji, who's in this room today. Thank you so much for mentoring me through this research, as well as thank you to these wonderful institutions. If anybody has any questions, I guess we'll hold those for later, but thank you.
Thank you so much, Drew. That was a really interesting presentation and an important presentation considering the epidemic in Los Angeles. So great work. I think people can type up their questions in the Q&A here while we move on, and then we'll have a discussion at the end, considering all of the different presentations and similarities in the themes as well. The next presentation is by Dvora and Omar, Dvora Uskop and Omar Nieto, and it's piloting teleprep information sessions, implementation strategy to increase PrEP awareness and optimize PrEP uptake among Latina cisgender women. So over to you for the presentation. Thank you.
Yes, of course, and thank you. And I should say, Drew, that I'm actually happy that we were presenting in the same group, because there are some similarities across both of the studies that we did, and I definitely feel like the findings that we present here can really complement that. So good morning, everyone. My name is Omar Nieto. I work at the Department of Family Medicine at UCLA, and I'll be presenting findings from our recent Ending the HIV Epidemic Supplement project, along with my colleague, Dr. Dvora Uskop. So noted here is our entire study team, and I should say before we start, that I just want to acknowledge that my other colleague, Elena Rosenberg-Carlson, who's kind of helping to support logistics, helped in the creation of this presentation. So I wanted to say that to start. Okay, so a little bit of background. So as part of National Institute of Mental Health EHE supplement project, UCLA CHIPTS received funding to pilot an implementation strategy to increase PrEP awareness and optimize PrEP uptake among Latina cisgender women through use of PlushCare. For those of you who are unaware, PlushCare is a standalone telemedicine app that exclusively provides virtual or remote delivery of clinical services, including PrEP. So some of the features that they offer is that they allow for asynchronous communication between clients and the provider. It allows patients to view their appointments, to schedule appointments all through the app, as well as have medication prescriptions delivered to a location of their choosing. I now want to discuss what our primary implementation strategy was for this project. So the UCLA study team trained staff at a community-based organization called East Los Angeles Women's Center to conduct information sessions with their Latina cisgender women clients to achieve the following goals. So first, we wanted them to raise awareness and knowledge of PrEP among Latina cisgender women, as well as motivating Latina cisgender women to consider using this telemedicine application, PlushCare, as an option to access PrEP. And I should just pause to give you some background about why we selected East Los Angeles Women's Center. So this CBO has a long-standing and trusting relationship with the specific population. And while they don't provide clinical services, they do offer sexual health education, referral to HIV prevention services, and all of their services are really rooted in this core idea of trauma-informed care. And that's because a majority of the women that they serve are survivors of intimate partner violence or sexual violence. And so really considering all of that, that made East Los Angeles Women's Center an ideal implementation setting for our project. In terms of our methods, we had two primary research activities. So staff at East Los Angeles Women's Center were tasked to complete monthly client engagement logs and to submit them to the UCLA team. As part of the client engagement logs, staff documented the number of women who participated in a session, the type of session. So whether it was a group session, an individual session with their clients, the language of the session, so if it was in English or in Spanish, as well as the number of women who expressed an interest in using PrEP and an interest in using PlushCare. And then descriptive statistics were calculated once we received all the client engagement logs. For the second activity, the UCLA team conducted qualitative interviews with Latina cisgender women clients who participated in an information session to assess the acceptability and appropriateness of the teleprep information sessions, PrEP and PlushCare. And then this data was analyzed using standard thematic methods. So for our results, I want to start just by providing you with a brief overview of our findings from the client engagement logs. So initially, we set the expectation, or at least the hope, that the staff at East Los Angeles Women's Center would conduct information sessions with 50 women, and they actually almost doubled our expectations. So they actually conducted information sessions with 94 women, of which 16 expressed an interest in PrEP and 6 expressed an interest in PlushCare. And the majority of the sessions were also individual. And as you can see here from this other pie graph, the majority of the sessions that were conducted were in Spanish with their Spanish-speaking staff at the agency. Before I turn it over to my colleague, Dr. Aidoo, to share some of the key highlights from our qualitative interviews with the clients, I do just want to give you some background information about their patient demographics. So in total, we conducted 20 in-depth qualitative interviews with Latina cisgender women who participated in an information session, of which 15 were conducted in Spanish. And this was actually with a staff member who we trained that works at East Los Angeles Women's Center. And then 5 of them were conducted in English. So the mean age of our participants was 41 years old, with our youngest being 26, and our oldest participant being 62. The majority identified as straight or heterosexual, completed at least some high school, were employed, had an annual income of $20,000 or less, and had health insurance. So at this point, I am going to turn it over to Dr. Aidoo, and she'll share with you some highlights from our qualitative interviews.
Thank you, Omar. I'm Dr. Aidoo. We do think it's important to allow the words of our respondents to speak for themselves as much as possible. Accordingly, I will be reading aloud some of the direct quotes where time permits. Consistent with the existing literature, this slide demonstrates that there is very little awareness and knowledge of HIV biomedical prevention options such as PrEP among Latina cisgender women. If I'm being honest, I knew nothing about PrEP before. I was totally unaware. When I attended the talk, I thought it was very interesting because they talked about things I'd never heard of, and that was a Spanish-speaking woman who was aged 46. Participants were asked knowledge assessment questions, including how long it takes for PrEP to become effective in women, and were generally able to answer these questions correctly as indicated by this quote. One woman aged 54, who's Spanish speaking, stated, "One of the things I learned is that you can take the pill daily, just like contraceptive pills. Women need to take it for more than a week to stay protected. It prevents HIV from entering the body in case you are with someone who's HIV positive. I like that information because it's another way you can protect yourself as a woman, as a man." In general, Latina cisgender women expressed that they liked the information sessions and felt the content was interesting, informative, and educational. This speaks to the acceptability of the session as indicated in the following quote. "I liked learning about this medication because I didn't know it existed. I hadn't heard of it. It was very informative. There wasn't anything I didn't like. I found everything interesting." And this was a Spanish-speaking woman who was aged 42. The health educators providing the sessions were viewed as knowledgeable and helped women feel more comfortable having conversations about their sexual health, and they found these information sessions to be relevant to their lives. Latina cisgender women generally express positive attitudes about PrEP and PlushCare and could anticipate potential benefits to their lives. Latina cisgender women liked knowing that PrEP is available as an option to help them protect from HIV. Latina cisgender women thought that PlushCare was time-saving, convenient, and easy to use. An English-speaking woman who was age 34 said, "You don't have to go anywhere. So if you didn't have a car, you want to save gas, or save the trip of not going, it can be all done at home or at work, whatever the case may be. So I think that it would be its convenience." Others felt PlushCare was a good option for women who were not comfortable going into a clinic for HIV services. They also liked the ability of being able to choose their provider and having the option to access the services in Spanish. Finally, some women liked that PlushCare was confidential. However, others raised concerns about privacy on the digital platform. As part of the qualitative interview, Latina cisgender women were asked to describe their level of concern about contracting HIV using a 5-point Likert scale, from highly concerned to not at all concerned. The majority of women reported that they were not at all concerned or only slightly concerned about HIV. The quotes here indicate that women did not believe they had sufficient HIV risk to warrant using PrEP or were in a season of risk. A Spanish-speaking woman who was age 50 said, "Although I don't have a relationship right now, I am interested, and I am concerned about what they explained to us because for me, it is very important to know more about this and be able to get that medication because the moment I have a sexual relationship, I know I will be protected in many ways." For our conclusions and future directions, the teleprep information sessions were very successful in raising awareness and knowledge of PrEP and PlushCare among Latina cisgender women clients. In general, there is a need to raise knowledge and awareness of PrEP among cisgender Latina women. Latina cisgender women generally view the teleprep information sessions as acceptable and appropriate and express positive attitudes about PrEP and PlushCare, and this implementation strategy of using the information sessions was shown to be an effective way to meet that need. The majority of Latina cisgender women who participated in the information sessions did not believe they were at sufficient risk to warrant using PrEP and/or PlushCare to access PrEP. It is especially important for strategies like this to reach women who are at higher risk or at high risk for HIV infection. Due to the limited time frame of the supplement project, only one participant decided to use PrEP, but this occurred after the project was completed. Based on feedback we received informally from the health educators, connecting women to PrEP services could take anywhere from 6 to 8 months, particularly because PrEP is so novel among Latina cisgender women. This suggests the need to tailor our implementation efforts so that it is mindful of the time required to connect Latina cisgender women to take care. We would like to acknowledge the East Los Angeles Women's Center, PlushCare, and the Los Angeles County Department of Public Health Division of HIV and STD programs for their support. And finally, we are excited to answer any questions that you all may have for us, and have also added our contact information should you want to reach out to us after the conclusion of this event. Thank you.